Okay, good day to all. This is the presentation of Group B from the BSN2E. The topic today that we are discussed is all about the muscle relaxants. Okay. As our presentation started, first of all, what is muscle relaxant? Okay. Next. Okay. Okay, what is muscle relaxants? The muscle relaxants are used in addition to rest, physical therapy, and other measures no, to relieve discomfort or are used to relax and reduce intention muscles. So they are typically prescribed for short-term use to treat acute painful musculoskeletal conditions. Um, Muscle relaxers are occasionally prescribed for chronic pain. So that's why muscle relaxers are or muscle relaxants are not a class of drugs, meaning they do not all have the same chemical structure or work the same way in the brain. Rather, the term muscle relaxant is used to describe a group of drugs that act as central nervous system depressants and have sedative and musculoskeletal relaxant properties. Okay, in this drug classification, no, there are two different types of muscle relaxants. First was the centrally acting muscle relaxants. Next, Manaji. Ay, bakong po pala, G. Okay, tama. Centrally acting muscle relaxants are used to relieve or discomfort associated with acute or painful musculoskeletal conditions. Typically, muscle tone decrease. There is no reduction in voluntary movements of the muscles, and possibly it inhibited at postsynaptic reflexes, and can administer through oral or parental treatment for spastic muscle spasms, tetanus, and uh, tetanus and possibly use an anxiety agent. No, also has been shown to be an effective in centrally acting skeletal muscle relaxant. Other measures in addition to this drug should be used. Next, then. Okay. This medication was used mostly for muscle spasm or muscle spasticity, where muscle spasms when there is a painful contraction and tightening for muscles due to the overuse, or some may cause some stress or anxiety. No, spasticity is a condition uh, in which the muscles are tightened or stiffening, preventing the normal fluids movement and the inability to control those muscles due to prolonged muscle contractions, like yung stroke, sclerosis, and cerebral palsy. Some muscle relaxant medication are used for other musculoskeletal conditions like yung lower back pain, neck pain, myalgia, which is yung isang condition experiencing overall body, yung naka-experience tayo ng pain sa buong katawan natin, no, dahil dun sa psychological stress na nararanasan natin. Severe injury or viral infection may possible, and it is possible for person yung having severe tension headaches. Next. Okay, as I said, yung centrally acting skeletal muscle relaxants is in for it works for only with the central nervous system, and under that is the medication typically used for muscle example of IT drugs, drugs that typically used for muscle relaxants in terms of central nervous system, like baclofen, carisoprodol, chloroxazone, um, cylobenzaprine, and etc. Next.
So here we have the mechanism of action. It acts by inhibiting apparent nociceptive input to the spinal cord, attenuating spinal reflexes, and inhibiting descending reticulospinal projections. So, in simple terms, muscle reluctance work by causing the muscle to become less tense or stiff, in which turn reduces pain or discomfort. They do this in different ways. As my groupmate mentioned, there are two types, which is for the muscle and for the brain and spinal cord. So for the indication, alleviation of signs and symptoms of spasticity may be of use in spinal cord injuries or spinal cord diseases. Some important aspect to remember for indication of centrally acting muscle reluctance in different age groups are, of course, spastic diseases, spinal cord damages, overexertion of muscle, and then that's it. So another is the dantrolene. It works directly on the muscle. So that is another indication or another work of muscle relaxants. It says here that muscle relaxants are usually prescribed to treat back pain in conjunction with rest and physical therapy. So in common relaxants, baclofen are mostly prescribed. Muscle tightness, muscle spasm, including those related to spine injuries, may be eased with the drug called baclofen.
So good day. The report that was given to me was the pharmacokinetics of the muscle relaxant. So first of all, let's start with the central muscle relaxants such as baclofen, cyclobenzaprine, and metocarbamol. Let's first start on baclofen. So in this PowerPoint, it was stated that it's available in oral and intraceutical forms and can be administered via delivery pump for the treatment of central spasticity. So first of all, let's go with the ADME of this, or for short, the administration, distribution, metabolism, and the excretion of each drug that was stated in this part of the PowerPoint. So for baclofen, the administration is shown in the PowerPoint, available in oral and intraceutical form, can be administered via delivery pump for the treatment of central spasticity. So for its distribution, as the patient consumes the drug, it inhibits our nerve impulses in the spine that causes the relaxation or relieves the muscle contractions. For its distribution, as the patient consumes the drug, it inhibits our nerve impulses in the spine that causes the relaxation or relieves muscle contractions. For its metabolism, baclofen metabolizes at a 15% rate in our liver. For its secretion, approximately 85%. The dose was excreted unchanged in the urine and the feces. Moving on to the next drug, cyclobenzaprine is available in a controlled release, oral form, or continual control of the discomfort without repeated dosing. For its ADME, cyclobenzaprine, the oral bioavailability of cyclobenzaprine has been estimated to be between 0.33 and 0.55, and between 5.35 ml is achieved through 4 hours. And over an 8 hours of dosing interval was reported to be approximately 177 ml per hour. So its distribution, the volume of distribution of cyclobenzaprine is approximately 146 liters. The combination of high plasma clearance, despite its relatively long half-life observed with cyclobenzaprine, is suggestive of extensive tissue distribution. So it is distributed through our tissues. So for the metabolism of cyclobenzaprine, it is extensively metabolized in our liver via both oxidative and conjugative pathways. And for the excretion, as it is extensively metabolized and excreted in our kidney, then it will be excreted by our kidney primarily as glucuronides via the kidney, and it will come out as a urine. So for short, after it was metabolized in the liver, it will be excreted as glucuronides, then it will go to the kidney, then it will be excreted as a urine. Moving on to the next drug, metocarbamol. On this PowerPoint, it is available in both oral and parenteral forms. So the ADME of metocarbamol is administered intravenously or intramuscularly. Pwede rin siya dun sa dalawang yon. So, but do not administer it subcutaneously. For its distribution, as soon as metocarbamol is absorbed, it will go into the kidney and the liver. Then the metabolites will inhibit the tissues of our body. So it's like it will go to the liver and the kidney first, then it will distribute to the tissues of our body. When for its metabolization, mhm, yes, metabolization. It is metabolized via dealkylation and hydroxylation. And for excretion, it was eliminated principally in urine as metabolites, 40 to 50% as glucuronide and sulfate conjugates, remainder as identified metabolites. And a small amount of 10 to 15% eliminated unchanged in urine. And very small amounts are excreted in the feces, so it can be excreted as a urine or a feces. So for the last, well, the pharmacokinetics of these drugs is basically most of these agents are rapidly absorbed and metabolized in the liver. But baclofen is not metabolized. But like the other skeletal muscle relaxants, it is excreted in the urine.
For the contraindications and cautions when using these agents, so first we have to assess the allergy to these drugs. So this is to prevent hypersensitivity reactions. Next is these drugs or agents under this classification are not indicated for skeletal muscle spasms caused by rheumatic disorders. So they do not benefit from these drugs. So they need another classifications for that. Assess also for history of epilepsy, central nervous system depression, and imbalance caused by these drugs may exacerbate seizure disorders. Next is cardiac function. So the functions of the cardiac muscle may be depressed when using agents under these classifications. And then condition marked by muscle weakness. Next slide. Okay, so also we have to be cautious when using this to patients with hepatic and renal dysfunction. So problems with liver and kidney could cause problems in terms of the metabolism and excretion of these drugs. then it could lead to accumulation and leading to toxic levels. So we have here baclofen. It is not indicated for treatment of spasticity that contributes to locomotions. So if you use these drugs, you will block the spasticity and you will lose the functions. Also, carisoprodol. This may be a safer drug choice than other spasmolytics in older patients and in patients with liver and kidney damage. So no good studies exist regarding the effects of these agents during pregnancy and lactation. So therefore, you must use these drugs only when the benefit clearly outweighs the potential risks. And lang, next.
Next, for the adverse effects, baclofen is tapered over 1 to 2 weeks to prevent development of psychosis and also hallucinations. For CNS or central nervous system, we have depression, drowsiness, fatigue, weakness, confusion, headache, and also insomnia. For CV or cardiovascular, we have hypotension arrhythmias. And for GU or genitourinary, we have urinary frequency, ureneresis, and urinary urgency. For GI or gastrointestinal, we have nausea, dry mouth, anorexia, and constipation. Tensanidine has been associated with liver toxicity and hypotension in some patients, and chlorzoxazone may turn urine into purple to red color. Next slide.
So, clinical importance of drug-to-drug interactions. If any of the centrally acting skeletal muscle relaxants are taken with other CNS depressants or alcohol, CNS depression may increase. Patients should be cautioned to avoid alcohol while taking these muscle relaxants. If this combination cannot be avoided, they should take extreme precautions. So, bakit nga ba hindi pwedeng uminom ng alcohol while taking um, antidepressants? Kasi drinking alcohol while taking antidepressants is generally not advised because alcohol can make depression worse. It can also increase the side effects of some antidepressants, such as drowsiness, dizziness, and coordination problems. One of the most dangerous kinds of antidepressants is MAOIs, or it's called monoamine oxidase inhibitor. Yan yung isang drug na hindi dapat minimix sa alcohol. Kasi certain chemicals called tyramines in drinks like beer and wine can cause dangerous spikes in blood pressure that may require immediate medical attention. Next na po.
Okay, for nursing consideration, assessment, history, and examination. Assess for contradiction or cautions for the use of the drug, including any known allergies to prevent hypersensitivity and reaction, cardiac depression, epilepsy, muscle weaknesses, or rheumatic disorder, which could be exaggerated by the effects of these drugs, pregnancy or lactation, which would be contradiction to use of the drugs, and renal or hepatic dysfunction, which alter metabolism and excretion of the drugs. Then next is assess temperature, skin color and lesions, central nervous system, orientation, affect, reflex bali- bilateral grip strength, and spasticity. Evaluation, bowel sounds and reported output, and liver and renal function test to determine baseline status before beginning the therapy and for any potential adverse effects. Next slide po. Next slide na po. And acute pain related to GI and CNS effects, disturbed thought process related to CNS effects, risks for injury related to CNS effects, deficient knowledge regarding the drug therapy. Next po.
So for the implementation with rationale, if you see any sign of liver damage, you should stop taking the medicine. And early detection of liver disease can help prevent actual damage. And if signs of liver damage occur, arrange for medicines to be stopped. And 60% of patients with hepatic damage, a prodrome with nausea, anorexia, and exhaustion is evident, and provide additional measures to relieve discomfort, keep rest for the muscle, and positioning to augment the effects of the drug under relieving the musculoskeletal discomfort, and discontinue the drug at any signs of hypersensitivity, reaction, or liver dysfunction to prevent severe toxicity. And if using baclofen, taper the drug to over 1 to 2 weeks to prevent the development of psychosis and hallucination. Use baclofen cautiously in patients whose spasticity contributes to mobility, posture, or balance to prevent loss of dysfunction. And if patient is receiving baclofen through a delivery pump, the patient should understand the pump and the reason for frequent monitoring and how to adjust the dose and program the unit to enhance patient knowledge and promote compliance. Next. And monitor respiratory status to evaluate the adverse effect and arrange for appropriate dose adjustment or discontinuation of the drug, and provide thorough patient teaching, including drug name, prescribed dosage, measures for avoidance of adverse effects, warning signs that may indicate possible problems, and the need for monitoring and evaluation to enhance patient knowledge and about drug therapy and to promote compliance and offer support and encouragement to help the patient cope with the drug regimen. Next. Next. And for the evaluation, we should monitor the patient response to the drug, the improvement in muscle spasm and relief of pain, the improvement in muscle spasticity, and also monitor the adverse effect, the CNS changes, the eye depression, urinary urgency, and evaluate the efficacy of the teaching plan. The patient can provide the medicine name and dosage, potential bad effects to be aware of, and specific ways to avoid them and therapeutic goals, and monitor the effectiveness of comfort measures and compliance with the regimen. Next.
Okay, next is the direct acting skeletal muscle relaxants. The direct acting skeletal muscle relaxants enter the muscles to prevent muscle contractions directly. As followed as direct acting skeletal muscle relaxants include yung dantrolene, botulinum toxin type A, botulinum toxin type B, incobutylin toxin A, or usually in the direct acting skeletal muscle relaxants. This was used for treatment of administration by of the fulminant metabolism of the skeletal muscles, driving to the harmful hyperthermia emergency. Hyperthermia emergency, muscle paralysis, loss of voluntary movements, and action that was blocking the neuromuscular transmission, and can be administered. This mostly of this medication can be administered through intravenously, and this medication usually used for or commonly used in the short procedures. Next.
So for the mechanism of action of skeletal muscle relaxants, it is used to relieve spasticity in neuromuscular diseases. So when we say neuromuscular diseases, the neuromuscular junction blocks the agent compound to the impulse from motor neuroending the skeletal muscle. So usually these drugs are classified according to two suggested mechanism by blocking nerve impulse transmission. Next, we have the indication. So the indication of skeletal muscle relaxants are often prescribed for musculoskeletal condition, including low back pain, neck pain, fibromyalgia, tension headaches, and myofascial pain syndrome.
For contraindications and cautions, so again, allergies to direct acting skeletal muscle relaxants. So this is for prevention of hypersensitivity reactions. Spasticity that contributes to locomotion, upright position, increased functions. So if you use these type of drugs, these functions will be blocked. So for patients with active hepatic disease, again, it will interfere with the metabolism of drug, leading to accumulation, or I mean, it would lead to toxic levels. So pregnancy, potential adverse to the fetus. So it is contraindicated for pregnant women, and also for the lactation, since these drugs can easily cross the breast milk that may cause adverse effects in the infant. So lastly, or next, the women and patients 35. Caution is applied because of increased risk of potentially fetal hepatocellular disease. Next. So dantrolene, it is contraindicated. So to patients with allergies, this is to prevent again hypersensitivity reaction. And then it is also contraindicated in the following conditions, including spasticity that contributes locomotion, upright position, or increased functions. So these functions will be lost if the spasticity will be blocked. Active hepatic disease. This can interfere with the metabolism of the drug, so it will cause liver toxicity. And next is the lactation, since it will cross the placenta and cause effects on the infant. And using dantrolene, so caution must be used in the following circumstances. So in women and in all patients older than 35 years old, because it will increase risk of potentially fatal hepatocellular disease.
For the adverse effects, we have for CNS, drowsiness, fatigue, weakness, confusion, headache, insomnia, and visual disturbances. For GI, we have gastrointestinal irritation, diarrhea, constipation, abdominal cramps. And for GU, we have urinary frequency, ureneresis, urinary urgency, crystalline urine with pain or burning on urination. Others, acne, abnormal hair growth, rashes, photosensitivity, abnormal sweating, chills, and myalgia. Dantrolene can cause direct hepatocellular damage and potentially fetal hepatitis. For botulinum, botulinum, toxins are associated with anaphylactic reactions characterized by headache, dizziness, muscle pain, and paralysis.
Clinical important drug-to-drug interactions. If dandrolene is combined with estrogens, the incidence of hepatocellular toxicity is apparently increased. If possible, this combination should be avoided. If the botulinum toxins are used with other drugs naman, it can interfere with neuromuscular transmission, which is the transmuscular junction blockers, lincosamides, quinidine, magnesium sulfate, anticholine esterases, sus, succinylcholine, or polymyxin or with aminoglycosides. There is a risk of additive effects. If any of these must be given in combination, extreme caution should be used.
Okay. Nursing considerations. Assess for contradiction or caution for the use of the drug, including known allergies to prevent hypersensitivity reaction, cardiac depression, epilepsy, muscle weakness, respiratory depression, which could be extracted by the effects of these drugs, pregnancy and lactation, which require caution use, renal or hepatic dysfunction, which could alter metabolism and excretion of the drug, local infections to prevent exacerbation of the infections. Next po. Assess temperature, skin color and lesions, central nervous system orientation, effects reflexes, bilateral grip strength and spasticity, respiration and adventitious sounds, pulse and electrocardiogram and cardiac output, bowel sounds and reported output. Liver and renal function tests determine baseline status before beginning the therapy and for any potential adverse effects. Next. Yun nga. And for nursing diagnosis naman, acute pain related to gastrointestinal and CNS effects, disturbed thought process related to CNS effects, risks for injury related to CNS effects, deficient knowledge regarding drug therapy.
Next is the implementation with rationale. To discontinue the drug at any sign of liver dysfunction. Early diagnosis of liver damage may prevent permanent dysfunction, and arrange for the drug to be discontinued if signs of liver damage appear. A prodrome with nausea, anorexia, and fatigue is present in 60% of patients with evidence of hepatic injury. So do not administer botulinum toxins into any area with active infection because of the risk of exacerbation of the infection. And you must monitor intravenous access sites of dantrolene for potential extravasation because the drug is alkaline and very irritating to tissues. Next. And next is you should monitor the intravenous access sites of dantrolene for potential extravasation because the drug is alkaline and very irritating to tissues. And institute other supportive measures like ventilation, anticonvulsants as needed, cooling blankets for the treatment of malignant hyperthermia to support the patient through the reaction, and periodically discontinue the dantrolene for 2 to 4 days to monitor the therapeutic effectiveness. Any clinical impression of exacerbation of spasticity indicates a positive therapeutic effect and justifies continued use of the drug. Next. And next is establish a therapeutic goal before beginning oral therapy with dantrolene to promote patient compliance and a sense of success with therapy. And discontinue the dantrolene if diarrhea becomes severe to prevent dehydration and electrolyte imbalance, and the drug may be restarted at a lower dose. And we should provide thorough patient teaching, including the drug name, prescribed dosage, measure for avoidance of adverse effects, warning signs that may indicate possible problems, and the need or monitoring and evaluation to enhance patient knowledge and about the drug therapy and to promote compliance. And we should offer support and encouragement to help the patient cope with the drug regimen. Next. So next is monitor the patient response to the drug. It is the improvement in spasticity, improvement in movement and activities, improvement in dystonia, facial lines, sweating with botulinum toxins, and we must monitor for the adverse effect. And we must evaluate the effectiveness of the teaching plan so the patient can give the drug name and dosage, possible adverse effects to watch for, and specific measures to prevent adverse effects and therapeutic goals. And lastly, monitor the effectiveness of comfort measures and compliance with the regimen. And that's the end of our reporting.